Welcome to another Texas in Conversation. In this interview, we'll be speaking with Betty Jo Rocchio, Senior Vice President and System Chief Nursing Officer at Mercy in St. Louis, to discuss our point of use solutions. Managing inventory visibility, documenting supply usage, and improving workflow efficiency becomes a challenge when multiple health systems are not integrated with one another. By consolidating processes and data into a single platform, you can eliminate the one-off point of view solutions and enhance productivity. So today we'll discover how a complete point of view solution can transform the operational activities in a supply chain and the clinical advantages of an integrated system. So thanks for joining me today, Betty Jo. And before we dive into our conversation about point of view solutions, can you take just a few minutes and introduce yourself and then tell us about your background?
Absolutely. Thank you for having me here today. It's my pleasure. My name, obviously, is Betty Jo Rocchio, and I am the Senior Vice President and System Chief Nursing Officer in the Mercy Health System. I've been with Mercy for 8 years. My clinical background is nurse anesthesia. So I'm a nurse anesthetist by background. I have worked in the past in Mercy in the perioperative space. I was the vice president of the entire system in the perioperative space. And currently since 2020, I moved into the chief nursing role. So since then, I've been leading the perioperative space with those leaders. And so I'm directly connected with our point of use, strategy, vision, and how we're moving across Mercy.
That's great. Well, again, we're very honored to have you here, and bringing that clinical point of view directly from the OR is going to be really intriguing. So I can't wait for the discussion. So tell me a little bit about the process of implementing a true point of view solution into a hospital system with the size of Mercy.
Well, first of all, it's careful planning. So it's really not about the point of view system necessarily. It's about how does your digital strategy leverage what you need on the supply chain side as well as in the clinical space. And so before you just start adding technology into an environment, especially a complicated environment like an OR, you need to understand what you're trying to accomplish. And I think that's the first rule of thumb before you start approaching any technology, but especially in that acute care space in an OR. And so that strategy is what drove us to take a look at how do we integrate supply chain, the clinical team in a very fluid fashion so we can accomplish what we hear in the industry today as clinically integrated supply chain.
Definitely. And I'm sure part of that strategy somewhere was, what's the value going to be of doing something like this? What are we going to get? What's that ROI and what's the piece of that? And so can you describe a little bit about the value, like a point of view solution or this type of integration has provided for your different healthcare departments, especially in the OR background?
Yes, as you know, the OR has been an extreme focus, although the cath lab areas are important as well. And I would even say the inpatient nursing units, depending on what your point of view system does to drive down the workload for your nurse. But the most maximum impact on that revenue generating function and reducing costs is going to be in the OR space. And so we'll focus there a little bit first. Like we said earlier, you have to know what you're trying to accomplish. And so setting out with clear goals is very important. And one of them is value. And value doesn't just come in the form of money. It comes in the form of coworker satisfaction, that nurse satisfaction at the bedside. It has to fit there as well as on the supply chain side. And so it's got to provide that value in the way of reducing workload on supply chain and the OR. So that's one of the things we looked at was reducing workload. The second thing that we focused on is more of the financial side of it. It's really cost per case. We have something called add-ons in an OR. When they don't get pulled into the OR for us, the nurse runs out and grabs things that they need for the case. So reducing the number of add-ons, keeping the nurse at the bedside, obviously is very important. And one of the ways we can measure the overall goals is through preference card accuracy. So how accurate are the items on that preference card on a daily basis, getting the items to the OR. And that's the linchpin, is that preference, that accuracy, because it affects both the supply chain and the clinical OR side. And so we tend to focus there first, take a look at where we stand on the metrics today, and then took a look at where that point of use solution would bridge the gap on where we were trying to go.
Well, that's great. Now, with your background being in a clinical setting, the OR, and now being, chief nursing officer for a system like that with, hundreds, if not thousands of clinicians and nurses, from that point of view, how has the adoption of a system like this affected your staff? Their workflow. Has there been, a noticeable difference in their productivity, even down to their just their morale and how things are going with the staff?
Well, if you know anything about an OR, we tend to be very lively, opinionated a member. So you're going to know clearly where they feel,
right.
Their pain points, and if it's working. And one way to know how they feel, number one, to ask them. But number two, take a look at your adoption metrics after you put in the point of use solution. And so when you take a look at the literature, which is very important as we looked at adopting a point of use solution, the literature will tell you adding technology into an environment is best accomplished when you, ahead of time, work with the clinical coworkers that are going to have to use the solution. And so that was the first thing that we did, was plan out our point of use strategy and the individual pieces that we were going to use with the front line. And so using an agile technology to put it into the OR was key, because then we obtained feedback every step of the way. And so they were actually leading us through the project development, not us putting a solution in and hoping they would adopt it. So we did measure workload very objectively. We used a tool to measure workload. Did we see that measurable workload decrease for them? And then up to 3 months, we measured their satisfaction to make sure that they were adopting it. And then in the background, we looked at the adoption metrics. Did we see preference card accuracy going up? Was our cost per case really dropping? And did we see those add-ons decrease? When you can see those add-ons decrease, you know that you're affecting that preference card accuracy in the right way. And the other measure is the supply chain feeling on the back half. Also concerned about them, not just the clinical team, because they're pulling everything to a case cart. We're using it in the OR, and then on the back half, what happens to the supply chain? They have to return everything. And so they really feel the weight lifted from their shoulders when preference card accuracy goes up. And the nurse feels it when the add-ons drop. So if the nurse stays in the OR, you can see it there. And if supply chain feels it through that reduced returns that come back to them, it really alleviates just a lot of the pain points on both sides.
No, that's great. From my background being, strictly supply chain for so many years, one of the things that I've tried to kind of get across to, the people that I talk to in the industry is that how can we better bring that clinical side to the table sooner in the phases, in the processes. And just to your point, especially in the OR, I always enjoyed, I was a little nervous, but I always enjoyed sitting down with clinicians, because one, they're going to give you great feedback. Whether you like it or not is up to you. Whether you like to hear that is always there. So what do you think the importance of bringing clinicians and how soon into a process like this? What do you think the value and I guess just the importance of that is?
Well, that's a good point. I would bring them in before you even start planning out what you're going to be doing, because this, Corey, nobody likes to be told at the end of the day, this is what we're looking at, and oh yeah, here's your part in it, right? That doesn't feel good.
Yeah.
And I don't know how you feel from your supply chain background, but our team on the clinical side, since we have the patient close to us, we always feel like what we need is most important.
Yes.
So it was a real game changer when we sat down with supply chain frontline and our OR frontline team and designed the system together. We'd just not done a project like that before. So we didn't take anything on in this project that didn't meet both of our needs. If one of us had to suffer while one of us gained, regardless of what we were looking at, we went back to the drawing table and developed something that worked out better.
That is a huge, that's a great point, and just a huge takeaway. I think that, you know, what's right for supply chain is not always right for clinicians, and what's right for clinicians is not always right for supply chain, and any of that. You can tie that back into any part of healthcare. So bringing the right people early into these phases, whether it's IT, clinical, especially when it affects the way they take care of patients, it's just huge, and I love that.
Well, and so you bring up a really good point I didn't mention. IT is huge in this, right? Because
Yeah.
when you look at it, it's a huge infrastructure change for IT. And so having them at the table at the same time is key, so they can figure out what they can do on their end to facilitate that flow that we're talking about between supply chain. If you bring them in at the end of it, you generally end up not getting what you need in a timely manner because they've got important processes they have to play in all this. It's not easy to connect disparate systems and try to make one continuous flow after the fact. We know that by working with Texas. That's probably some of the hardest work, is how do you make the technology work into the workflow that you want to design? And it takes all of us.
Yeah, and I think the earlier we can tear down those silos and those roadblocks or whatever the cliche may be, breaking those down as soon as possible in a process like this is just, it's keys to success.
Absolutely. Absolutely.
So, move on a little bit around. So as we introduce a data-driven methodology, it can really transform a hospital's operational activities from across the board. Kind of what are some of the ways that you feel and you guys have used in your own world, analytics and, just key improvement measures, process improvement measures? How has that improved nursing clinical efficiency?
Well, so when you take a look at it, the OR generates large data sets. Here's the problem with it. We have data sets on the supply chain side and we have data sets on the perioperative side, right? One is about inventory, usually, those data sets on the supply chain side. And the other data set on our clinical side is really around patient things. And so we've got supply chain working in an ERP system, right? We use Lawson. And we've got the clinical side working in the EMR, which is Epic. They are both documentation systems for different things, but there's no system of action in there. And so when you start to do that, what you notice is having individual analytic data sets that we can't both see and work off of really drives the wrong workflow. And so
You're going two different roads. You're going down two different paths.
Yeah, you're in two lanes, right?
Yeah.
But here's the thing that I learned as I tried to clean up preference cards, right? That's the main goal, is preference card accuracy for both of us, actually.
Mm-hmm. Yeah.
That's the common set, right? That says we either made it or we didn't, right? Around preference card accuracy. But even the definitions around preference card accuracy are different on the supply chain side because we're working in a different system. And it was different on the clinical side because we were in Epic. So we didn't even talk the same language, but we were expecting a continuous workflow for the patient, right? And so it's a little bit hard to do that. And my realization of putting in the point of use system was that now we're working off of one data set, right? Because you're pulling to the case card in an OR, right, out of Texas, right? And we're consuming it from Texas and it's pushing it into the EMR. So we are both working in that system of action of point of use. We use Texas, right? But you're working on both sides. So the data set becomes visible on both sides and we're looking at it in the same way. And that transforms how we work together. Not only for the patient, but between ourselves to build the relationship. It kind of breaks down walls.
Yeah. And I love that system of action that you speak to. I've heard you say that in the past, that that's what we have to do. And when we're not working in that same system of action, we have to figure out how to get in the same lane. We have to figure out how to merge that together. So we're, because we don't talk the same language, but we need to be able to learn the vocabulary and speak that same language.
Yes. And one of the things we did, we realized preference card accuracy was the common kind of analytic that drove us both. right? We were both trying to clean it up. Supply chain wanted us to clean it up because they're pulling more things and returning more things, right? We figured out we were pulling and returning somewhere between 38 and 42% of all of our items, like never were used before we put in point of use. And so supply chain would be angry, like, I don't know why these clinical people can't get this straight,
Right.
right, on
Yeah.
on what they want, you
Right.
know? And we would be like, why can't supply chain get it right and pull the right things? Because we're still running out of the room, that add-on
We
we
were
talked
we
about.
were in two lanes, just like you said earlier.
Just kind of crossing at weird points, but not managing to the same goal, right? We didn't want to end up in the same place, but we
Right.
weren't on the right path, right? And so
That's
it's
huge.
interesting when we can get in alignment what we can accomplish. And then to your point about analytics, at the clinical front lines, it wasn't a system of action that we're driving the analytics. It was more of a passive system, which was what was on the preference cards, which we knew weren't right in the first place, but we were accounting for those and expecting to drive results off of that. And so now with the clinicians using scanning or point of use, we know exactly what we're using. We've cleaned up our data sets together and we're able to get the preference card right. And we saw preference card accuracy go from about 43% before the point of use, clear up to 78 to 82% preference card accuracy. That's
That's amazing.
amazing,
That
the
is.
number of items you're returning. When you take a look at that accuracy, they were spending the majority of their time putting things away. Now they're spending the majority of their time working on inventory, par values, the things that matter to the supply chain.
Yeah, that reallocation of resources for supply chain and clinical side, because you know, not having those accurate preference cards is not. It doesn't only just affect supply chain. You guys are running around like trying to find the right, because you may not have the right items on the right preference cards or whatever that is. So there's a lot of time and efficiency lost when those are crazy.
Well, let me give you an example of that. For us, that efficiency, that nurse efficiency, is staying by the bedside for patient care.
That's
We're
the
really,
number one priority.
yep, number one priority. But before we put in point of use, we were running at about 46% add-on supplies, meaning we were circulating and returning, right, 38
Mhm.
to 42%. We were also running out of the room
Right.
46% of the time to grab things that we needed. So it kind of looks crazy when you put it in terms of the analytics, doesn't it?
Yeah.
Like, who would do this all day long? The nurses going back and forth, and you can see where the frustration mounts. But after the point of use, right, we dropped it somewhere between 20 to 22% add-ons. You're never going to avoid an add-on because people are unpredictable in what you need as you're in an OR setting. But that's a lot of items to reduce that, to reduce it by 18 to 22%. That nurse is by the bedside, which again is increased efficiency for her. So,
And it increases, just I'm sure it has effects on nursery tension, you know, things like that are critical for a hospital organization such as yourself. I mean, you it's like a mother hen. We have to take care of our own. So, taking care of those clinicians and letting them do what they're trained to do.
that's 100% right. Nobody goes to nursing school or goes into an OR to take care of patients
That's
to
exactly
look for things to help take care of them.
Yeah, they're not meant to do supplies. They're meant to take care of patients.
Otherwise, we just open up a shopping center and let them grab everything they want right
Just
before the
whatever.
case.
Yep. That's great. So when we talk of this whole, and you mentioned it earlier about that clinically integrated supply chain, that clinically integrated system, and such like point of use, hospitals have the opportunity to monitor their supply chain performance a lot more consistently. So when you have that one platform that reaches all the way across. So I guess can you describe just a little bit around the areas that have benefited from like a combined clinical supply chain approach? I know the supply chain and the clinicians, but is there other areas that really benefit from that?
Well, we're just going to go there right off the bat, and it's finance. When you look at accounting for it, right, that's less waste, less inventory that we're keeping on the shelves, and there is a cost to having inventory. My finance people tell me it's about 27%, right? The cost of carrying, they call it carrying costs, right? And so we're able to not only know what we need and have it available, we're also able to do some demand planning based on cases coming up. So we're just not stocking everything we might need for a month. We know what's coming up, right? We can see it in our EMR, and we're able to translate it over into Texas on that side of it, and be able to see what we're going to need for cases, right? And so that allows us with a more degree of comfort not to have everything in the kitchen sink, even in inventory. So we're paring down what we need, reducing carrying costs. In addition, we're not physically counting inventory anymore. I know this sounds crazy. We're in the 20th century. Before we had a point of use or a perpetual inventory management system, we would do physical counts of everything across 260 some ORs, right? Like that's insane, but that's what we were doing. Today we cycle count, right? Yep. Here and there. Just it's more of a check, but when we go to get final inventory, it's in our system. We don't have to worry about it. It's a big savings. So finance is always on board with this. You've got the clinicians, you've got supply chain, and the surgeons, right, in an OR, or physicians if you're in a cath lab, are benefiting because they can see a cost per case in the OR. And so that's the other group that's a stakeholder that has really benefited from this, because before point of use and accounting for each supply item, you couldn't see a cost probably ever. Some physicians did not even know what things cost. They couldn't get to a cost during a case. So it allows them to make the right decisions around value for the patient. So for example, in an OR, now we can scan 5 different staplers. And if the physician wants to know the cost of them because they don't need an expensive stapler, we can tell them right now what it is. And then they walk out of the OR with kind of a grocery store receipt of what the cost was for that case. And so it allows them in the moment to be able to work with us and look at their preference cards or what they used right after the case. So it's been a game changer for our physicians as well.
Right. I love the fact that you brought up physicians, because sometimes they a lot of times we don't think about the physicians. We think nurses and we think that, but the physicians play a huge part of this. And really just bringing, I feel like that if we can bring the ammunition to all parties involved, we have a better way of attacking supplies and cost of care and all those things that are top headlines these days.
That's right. And it's value, right? It's the one thing that we don't see in the OR that ends up in the analytic data set is we're able to produce even long-term patient outcomes against cost or what implants we used. So we're able, that's a lot of value. When you consider the way the payment model is going in this country, we're going to have to be able to account for that to prove value long-term. So it might be beneficial to spend a little bit more money on an implant if we're getting more long-term outcome from it for our patients. Right. So we're starting to take those data sets because we know they're right. With point of use, we know they're correct. We're not guessing that a nurse entered a number right, but we know that 100%. And so we're able to take those data sets with a lot of reliability, work with our vendors, right, our manufacturers, and say, this implant isn't worth, right, $400 more. Or, yes, it is. We want to buy more of this product.
Yeah, it's not always about the cheapest item. You have to tie them both together. The being good stewards of our money versus the outcomes and the patient quality.
That's right. You're 100% right. And the other thing that it's done is allowed us to do expiration and recalls much faster. Mm-hmm. So ensure on the quality side, we're not implanting things that are expired because they don't get into the patient room because supply chain knows that things are expired by the scanning to the case cart. And if they didn't catch it for some reason, which is rare, the nurse will catch it when she scans, the implant or the product we're putting in.
Yeah, so cut it off at the path. Yeah.
That's right. So quality is another stakeholder that's happy, right? They're seeing less issues with what we're putting in patients, and we can prove the money we're spending is driving the value that we want.
That's great. Earlier you mentioned, you talked a little bit about inventory and visibility and finance, and so with the ability to better optimize true inventory visibility when you put in a solution like this, automate supplies and reducing that product variation, that's another big piece of that we talked about a little bit about. Has there been a significant difference in Mercy's cost savings since putting in a solution?
Not that that was the reason we put it in,
Right.
but there is. So think about the power. We just talked about the power of seeing the cost in that actual OR.
Hmm.
There's some power there, as well as it showing up. We use analytics on the backside for cost per case. And so we can work with the physicians to reduce down what's on the preference card so it never makes it to the sterile field. And the other thing we do is take a look at analytics in the background to compare all surgeons, will say, that do total hip implants. We can see very clearly what everybody's costs are, and it allows surgeons to work within the bounds of what's acceptable variation, and that's what reduces cost per case. Them working together, not me or our OR nurses telling them, no, that's too expensive. They make those decisions ahead of time before they get in the OR because they can see the analytics. And so, there's been, since we had our point of use in for a couple years, and we're not even live in all of our ORs because we're taking our time to make sure we put it in correctly. There's been over a $10 million savings. That's a lot of money.
That's huge.
Just because you're able to, again, it's the value of seeing the analytics and trusting it, right? It's not only that we used to see them before, the physicians didn't trust it, but now they understand that point of use process. They're like, yep, I can trust that because they see it every day. Yeah. So it's interesting how there's no more fights over whether the data's right.
Right. And then, also from your point of view, from the C-suite level, when you talk about savings like that and the reallocation of resources and back into patient time and patient, quality, how's the adoption been at the C level at Mercy?
Well, first of all, in the beginning, it took a 25-page business case to get anybody to understand this. That's how complicated it is. So I feel for the people trying to sell point of views because it is a hard sell. It's expensive, but the return is there, but you have to be able to prove it and stick with it. You have to be committed to the strategy to be able to see it show up. But once it does show up, it's amazing what happens. And so planning what that's going to look like before you get into it to make sure you're measuring yourself really all along the way, Corey, is key. And it's not about supply chain saving money. It's not about the clinical team saving money. It's about what we can accomplish together. Right. And so we continue to tell that story as well.
Yeah, and it was kind of the perfect segue right into this last question that I have for you is, if I'm a hospital supply chain leader and I'm really just we're having hard times with some of the things that we've talked about today with physician preference card optimization, with supplies, returns, whatever that is. What are some tips, I guess, that you could give from the clinical side to a supply chain leader saying, this is a good starting point. This is where we need to bring our healthcare organization together so we can adopt this together.
So I think the right starting point, and it's where we started, was a conversation around preference card and preference card accuracy. It's our common language, right? Supplies are on there. You call it a pick list. We call it an open and PRN column, right? But actually, it's the same list of supplies. And so I think that is our common goal. And I would highly suggest you develop a common definition around preference card accuracy, because that really pulls in the supply chain side in a very analytical format, and it pulls in that clinical side. Taking a look at that same data set, it kind of pulls that data set into view so you can see that it's the same thing. We generally know it's the same thing, but we manage it so differently that we can't have two different targets, right? And so we've got to agree on what that target is, and it's preference card accuracy in my mind. Think about in your supply chain days how many times you've had a project around helping the clinical team clean up preference cards only to have it end up, it's the sustainability of it.
It's a broken record, and we've never, it's so hard. And that's why it's like, it's just great to talk to me and hear you talking about, Mercy's journey through that, because, a lot of people on the supply chain side, we have those same struggles. But in the same token, is we got to get in that, like you said, that same lane. We got to merge together. We got to develop those same metrics that we're measuring ourselves by every piece and every part of the way.
That's right. And until you do that, there's no sense of trying to have a common strategy. You know that relationships and having a common goal is what's going to drive this. And so, you know, looking at one side versus the other and not taking that into consideration, it drives you in the wrong direction, right? That's what clinically integrated supply chain is to me, right?
That's
it's
right.
that supply chain working alongside a clinical to drive whatever you're driving, right? And so I think that's what's most important. So at the end of the day, it always comes down to relationships and having a common goal and defining that goal so you know when you hit it.
The strength in numbers. We can do this together. That's right.
We can do it. We can do it together.
Well, Betty Jo, I just thank you so much for your insights today. This has been, this has been great. It's been very informative, as we're developing these Texas in conversation pieces. And I really want to thank you for your time today.
Well, and I really want to thank you for your partnership and helping us do everything we've done in Mercy. And so we have a great relationship and partnership as well. And I thank you for that.
Thank you. And thank you to our viewers. And if you need support with integrating a point of view solution within your healthcare organization, Texas is here to help. At the end of this video, you have the option to speak to one of our healthcare supply chain experts, or you can access our ebook on the missing pieces in your supply chain puzzle. Thank you all for joining us. Thank you, Betty Jo, and I'll see you next time.